Hi everyone, welcome to Value in Health Week. My name is Melanie Thomas. I'm the National Clinical Lead for Lymphoedema Services in Wales. What we're actually going to do this morning is tell you about the development of our PROM, the patient reported outcome measures that have taken a lifetime to do, but we're nearly there. So I'm also going to introduce you to my colleague, Dr. Marie Gabe-Walters.
Hi, good morning all. So I'm Marie. I work with Dr. Melanie Thomas and I'm a researcher within the Lymphoedema Network Wales team. And I'll hand you back over to Mel now.
Okay, so it's back to me. So lymphedema, I'm sure many of you do know about it, but some of you don't. So lymphedema used to be very much associated to breast cancer, but actually that's about 10% of our workload at the moment. So it's dramatically different to what it was many years ago. But when you look at lymphedema, it can affect any part of the body and it can affect any age. Although we do have an elderly population that is more common to have lymphedema. But saying that, we've got 350 children on our books. So when we talk about LymProm and the development of outcome measures, we had to think about this could affect everybody and everyone. So if you think about it, it could be surgery, from plastic surgery, from trauma, could be cancer patients, medical, diabetes, dermatology, but then your pediatrics and then your obesity, urology. So it affects everyone and everybody. So to start us off on value-based, I'm going to tell you about Megan. So Megan was a lymphedema patient. She's long-standing, who's had lymphedema for many, many years. She's housebound, she was immobile, and she had carers going in 3 times a day. Now, we could query how immobile was she and what were those carers going in 3 times a day for. But she also had community nurses going in, and in the last year, she'd been in and out of hospital with cellulitis, costing a lot of money, but averaging 60 days. When her legs looked like this, she also had bilateral knee replacements, and you can imagine she ended up with chronic wounds. Now, when I asked her story, tell me about your valuable journey. Where have you been? What's happened to you? She said she'd been back and forth to the GP for infection, cellulitis, for pain. The district nurses were coming out. She got referred to a dermatologist, who then referred her back to tissue viability, who then referred to vascular surgeons. Orthopedics got involved because she had this chronic pain in her knees. Plastic surgery got involved because the wounds didn't heal. She was falling a lot, so Falls Clinic got involved. And then you've got all of the allied health professionals who were also putting their input in. And not forgetting the number of cellulitis admissions that costed a huge amount of money. So if we talk about value-based healthcare, what did Megan really want? So Megan gave me consent for her legs. She didn't give me consent for her face. So I've put a different Megan in the middle. But really, that's all Megan actually wanted was, I want the pain sorted. I want to drive my car. I want to be able to go and see my friends so I can have a bit of independence. So that's really all she wanted. Now, I'm not saying that as clinicians, we didn't ask her this, but she never really stressed the importance of wanting to be independent. She wanted to drive her car. So when we look at Megan's story and the consequences of her pathway, she'd been in and out of hospital, emergency departments, costing around 24,000. Wasted resources, prescriptions. Diuretics don't work for lymphedema and yet they're continually given. Inappropriate garments, dressings, wasted appointments with the GP, the consultants. Everybody seemed to be passing her on to somebody else and not actually sorting her out. Falls. Because she was a larger lady, when she did fall, we had to get 2 ambulance crews there to actually get her back on her feet. You can imagine the cost of that, as well as the social care, the community nurses, and really just a bit of evidence. People who cannot work, they don't pay their taxes, they claim benefits, and 80% of lymphedema patients take time off work, 8% have to stop completely. And we know that those who have lymphedema have a 50% recurrent episode of cellulitis, and we know that 50% 90% of this uncontrolled pain. So when you look at the cost, then £82,000, but she still can't drive her car. She still can't go and visit her friends. She still can't be independent. So what would the value-based pathway look like? Well, she could have gone to a GP who knew all about lymphedema and could have referred her there and then. Or she could have been admitted with cellulitis and the ward knew about lymphedema and they would have referred her. They could have issued a PROM and then they would have found out that the exact thing that she wanted. She could have had her pain relief, bandaging with the lymphedema service. She could have had compression stockings and she could be back driving her car because she's in garments and she's in control. And if you look at the cost difference, then we're averaging about 82,000 compared to 6,000. And that's a huge amount of money. So what could we have done to solve the problem sooner? And it's the good old PROMs. Now, PROMs, questionnaires, self-reported health and quality of life, they're going to target what we do, what we give to what the patient needs. Now, with legs that looked like Megan's, straight away, good meaning professionals will want to solve the problem that we think that they need, not what they want. So for her, she had open wounds, we would want to heal those wounds. But really, that would involve daily bandaging, daily people coming to your house, that you can't have your independence. So by PROMs, we could drive the value, we could drive the quality in care. So what have we done with PROMs in lymphedema? Now, for many, many years, we've actually used the thermometer, the impact thermometer 0 to 10, asking patients about the impact lymphedema has on their life. But unfortunately, they were all part of our assessment documentation. So the patient didn't fill them in themselves, the therapist would ask the questions and we would score it. Now you can see at the bottom of the paper, at the bottom of your screen, you can see pain, anxiety, hobbies, work, and so on. Now, they were actually filled when we did the LVA study, so lymphatic venous anastomosis. We did a lot of benefit realisation and we knew that in order for us to get the funding, we needed to be able to prove that patient-reported outcomes were improving. So this is how it all came about with our PROMs. So I'm going to pass you over now to Marie, who's going to tell you a bit more about what we've done.
Hi, so as Mel said, the initial sort of focus of the PROM tool looked at a sort of set of items that were agreed by stakeholders, so by that therapists, but also patients lead-in, and from what was identified in the literature. We also then looked at what PROMs were already available for clinicians to use, particularly disease-specific PROMs, so those used in lymphedema. Looking at the literature, there are a few available. We focused on adult care at this moment, but it's not to say that what we're doing isn't going to be replicated in children, which is another project on the way. So looking at the lymphedema PROMs that are available and published currently, there were around 10 that were reviewed, but they had a number of different items. So we go back to what Mel had said, and we had a short set, sort of 12 items that looked at important outcomes identified by our patients. But the ones that were possibly in use across lymphedema had a varying amount of items, some of them up to 45 that were published, others had 90 items. So as Mel said, it was embedded within the lymphedema service and the clinic appointments. So one of the key things that patients wanted to maintain was the short and sweet nature of the PROMs that the Lymphoedema Network Wales and lymphedema services across Wales were using. So then we looked at well, the validity and how well the existing PROMs worked. Some of them focused on an area of the body. So lymphedema can affect upper limbs, lower limbs, midline, head, neck. So some of the PROMs that were available focused on one area. Again, it was a priority of patients to have a one form that would potentially meet their needs. We looked at how well other PROMs were validated, looking at TOE and COSMIN, their guidelines, and none of them quite filled all the boxes, particularly none of them covered all the 12 items that our patients and our clinicians identified as being important. So what we did then is we developed this tool, as you can see on your screen, which is called LymPROM. This is Lymprom more recently, but initially we piloted a 12 item rather than a 13 item Lymprom with a cohort of patients across Wales. And this is all from late last year to early this year. In total, we recruited 128 anonymous completions of the Lymprom. Some items were left blank, so you can see on the screen that some items have got the non-applicable option tied to them, but the initial pilot didn't have all of the non-applicable items there. So that's, as we've gone along, we've incrementally developed Lymprom, and we've now added non-applicable to the items that patients were typically leaving blank. Of the 128 forms that we had completed, 84 were completed in full. So we looked at how well the items sort of related with one another. Overall, the internal consistency, so the Cronbach's alpha was excellent. And all the relationships that we could see between the variables were positive, and no items were identified for removal. So we kept the 12 items, and we've put together a publication which is in press currently, looking at the early development of Lymprom. So based on the 128, we've also got an idea that the Lymprom itself was fairly feasible. So we were including it within patient appointments, and that it was quite acceptable for them to complete pretty much as they were waiting to be seen by their clinician. So we took this development and validation work another step further, and this will take us to pre-COVID in early March, where we initially started with patients that were new to service, asking them to complete Lymprom at home before they came for their very first appointment. And then approximately up to 2 weeks later, come for their first appointment, we'd ask them to complete Lymprom again, alongside the EQ5D5L, which is a generic quality of life outcome measure. So this was in early March. Things slightly changed, and we've also, as I come to on the last few slides, talk about the new direction. So we had to do what the best we could do in validating Lymprom, bearing in mind the circumstances. So we looked at test-retest reliability. That was the most challenging part, I would say, for this, because we had their initial face-to-face appointment, and then we were planning to be back for their next appointment, which would be around 3 to 6 months later, to look at potential changes in their Lymprom scores. But at this point, the follow-up is now being primarily conducted over the phone by the health board. So I was sort of collating in the anonymised completions of Lymprom. For those that were completed at home and then in clinic, we were also looking at were the scores roughly the same. So all in all, we've got the data to hand now, so that's going to be sent off to be analysed. We don't have the figures yet. We did find that we lost a few at follow-up in their appointments 3 to 6 months after March. But on the whole, patients still found it easy to complete over the telephone. And that will bring us on to future directions with Lymprom. And as I mentioned, we established Lymprom against the EQ5D to look at construct validity. We also had the opportunity now with COVID, because we had to slightly change tact on how we were developing and testing. We then asked all Welsh health boards to ask patients to complete Lymprom, whether it be for some of the face-to-face appointments or over the phone or via post with the EQ5D. And that's gone since March to present times. And we've had great return of data for this. All Welsh health boards have participated, and we've had over 150 forms in with the EQ5D. So this data will need to be cleaned, but so far I expect that we've got quite good completions. So we also, while doing all of this, asked therapists and expert patients to look at Lymprom in terms of its content. So how relevant the questions were within it, and how comprehensive the tool was, and how understandable it was. So looking at using a content validity index, respondents were scoring the relevancy and the understandability on a scale of 1 to 4, and overall the content validity for Lymprom on the whole was excellent. The range for the items, the majority were also excellent, but one item in particular asked about whether or not there are any overlapping questions within Lymprom, and that scored the lowest at 0.43. We slightly anticipated this because a lot of the items within Lymprom are related to one another. They do cover the underlying domain of health-related quality of life, but it's something that we're going to look at further as we go along. In doing the sort of work with expert patients and clinicians, we also had the opportunity then to look at the form and develop it a bit further. So we've had some changes made. So for example, pain as the first questions on Lymprom was initially just pain, but now it's been amended to discomfort based on feedback from patients saying that, for example, pain they might not score some of the important discomfort that they also feel with their lymphedema. We also reordered items so that they were grouped together, made more sense. We tried to keep the more sensitive items not at the top, not at the bottom of the list, but somewhere relevant in the middle. And some items were removed or reworded. So we've got intimacy and desirability on the left. Previously, it was sexuality, intimacy and desirability. But again, even with the NA box there was some participants that were leaving it blank. So we still need to continually review feedback from patients to make sure that this form is still meeting their needs and that it's delivered and completed in the most appropriate way. So we also have opportunity to look at the data that we've collected from patients, just in terms of, well, what is the impact of lymphedema on their daily living? So this is going back to the initial cohort of 128 patients that include new and follow-up patients. Very, very few of the respondents had absolutely no impact from lymphedema. So that's those that scored 0 on all of the items. So only 5 respondents scored 0 throughout the form. Few, again, scored a maximum 10. No, none at all, sorry, scored a maximum 10 in all of the forms. So we then looked at ceiling and floor effects, which we've not to have any evidence of within the Lymprom based on overall scores. I then looked at the key problems for patients completing the form, and the top problem reported by about 49% was shopping, particularly shopping for clothes and shoes. So Mel touched on one story that talked about the challenges for a lady in terms of pain, but in fact the challenges can be far more subtle, within the life. Without direct question, there's opportunity for these problems to be missed with patients and support not offered. Body image was another key priority for patients with lymphedema, and the mobility their walk-in was often affected. Around 27 of the 128 scored at least 1 in all items, and of these, over a quarter scored over 5 in all of the items. So we've got an idea here that the Lymprom is identifying problems with patients, something that would allow clinicians to then target their services, their therapy, or refer on if needed, to ensure that the patient outcomes, their goals are met. And again, all of this work we plan to write up, publish, and ensure that it makes meaningful change. So throughout the slides, I've sort of hinted at COVID-19 and the impact of this in terms of Lymprom. Lymphoedema Network Wales and services across Wales for lymphedema were well prepared potentially for some of the difficulties and challenges we've all faced in the recent pandemic, in particular with the movement towards value-based healthcare. Services were already developing virtual ways of working. So one of the key next steps for us has been, and we are going live with pilot data in 2 Welsh health boards, of digital integration of Lymprom within the doctor-doctor platform. So that would allow the LymPROM to potentially be used to not only manage and prioritise care, but to also potentially manage, prioritise referrals and discharges in and out of the lymphedema services. So in having the electronic LymPROM, patients will be able to complete it before their appointment, but they can also complete in the appointment and on paper if paper is their preferred option. So this will align quite closely with value-based healthcare and ensuring that we're meeting the needs of all of our service users. Again, this will all be written up and published. And to also mention that we've got a patient-reported experience measure, LymPREM, which will also be piloted alongside Doctor. So we'd have patients completing LymPROM before their appointment, having their appointment, and then reporting on their experiences. So there's lots of opportunity to track our successes, but also to identify if we need to adapt what we're doing. Yes, sorry.
Net. Oh, I'm very sorry. And it was going so well. Okay, so what? So at the moment in Lymphoedema Network Wales, we've got 3 categories of patients. We've got palliative, end of life, that must be seen within 2 weeks. We've got urgents that are seen within 4, and then we've got routines that must be seen within 12 weeks. But as you can imagine, because of the capacity gap, not often are those weeks being met. But let's put it into a PROM-based service. So ultimately, this is a palliative patient. She's completed her PROMs. She's got minor lymphedema. And when she's completed her PROM, as you can see, they're all number 1s. But we would bust a gut and we would get her in within 2 weeks because she's an end-of-life palliative patient. However, her symptoms are low. Compared to a routine referral, which 12 weeks, but more than likely will be around 20, they're all 9s and 10s. Now, this is a patient who can't get his shoes on, can't get to work, has got significant pain, which is really affecting his whole life. But ultimately, we would prioritise somebody with low priorities, low needs, because what's based on a referral. So I'm delighted to say that actually lymphedema services in the future, all new referrals will become a PROM-based driven service. So we went live in Aneurin and Bevan yesterday, and we've had 13 LymPROMs back in, and we're going live in Swansea Bay with Doctor in 2 weeks' time. So it is very, very exciting what we're doing. Now, some people have said, what about the scoring? So what if somebody answers 6 questions and then the total score is between 7 and 35 or 36, 47, or if it's more? And you can see up on the screen at the moment, this is a patient that's completed. Their score is 11. We just add them all up and they've answered all 13 questions, but their score is less than 11. So really, we would see them within 12 weeks, but we would ring them first to determine the need for that appointment. Do they actually need to be seen? Could we see them virtually? Could we give them the advice? And then we could discuss discharge. So ultimately, what we're going to be trying to do is make sure that those patients that need to be seen face to face are the ones that need to be seen. So what else are we doing? Obviously, Lymphoedema Network Wales, for those who know us, we don't sit on our laurels, we keep going. Cellulitis is a massive new improvement programme, value-based, that we've started. But what surprisingly, there isn't any PROMs for cellulitis patients. So although we've got lymphedema ongoing, we're also now creating Cellu-PROM, copyrighted of course. And the biggest difference between the forms is actually the fear of cellulitis. And it's quite surprising that anybody who's had a cellulitis, the fear of having it again, are coming in at 9s and 10s. So we know there's a lot of work, but that's the next stage that we're also doing. So basically, thank you so much for listening to us. I think we're bang on time. So I'm Melanie Thomas. As I said, if you need to email me, you're more than welcome. Marie's email is also there, and I am on Twitter, which I'm not very good at, but I do try now and again. And are there any questions for us?
So I can see one of the questions in the bar regarding item response theory. Of course, we're going to be doing more analyses. I just didn't have opportunity to put everything in the slide. We don't have the data, but we will be using the RASH methods to explore all the data, factor analysis. And just to touch there, Mel talked about scoring. We currently have no reason to weight the items, so they're all equally weighted in the scoring that Mel showed, but that is something we will potentially revisit with further data.
Right, so there's one on mental health services. Do you want me to answer that? Okay, so I think I'm back live. Okay, so somebody else has asked us about mental health services. We do have quite a few patients who have got mental health issues. What we are finding for those patients, if they attend with carers, then the PROMs were being completed in conjunction with the patient and their carer outside of the therapist being there. But it's quite interestingly, the other thing that we're noticing is since COVID, the anxiety scores are escalating, but that is something that we will need to look at, because potentially, obviously, the anxiety question is meant to be, depression is meant to be related to lymphedema, but we know that COVID is having an effect. So we do need to look at that. Is there any more questions for us? We've bombarded you. The other thing that I would like to say, I've got a bit of an opportunity now, is we do understand that based on education, knowledge of a patient, maybe their socioeconomic background, they may complete the PROM differently to somebody with less knowledge. And what I mean by that is if they really want to be seen, they will put 10 in every category. All those patients are rung afterwards, but also if a patient is put in 10 in categories, then it's their own patient reported outcome and they do need to be seen. But we do give patients opportunities, on the phone without the PROM, to discuss what their options are. I think there's another question now. Could you explain the scoring behind the tool? So if I pass this over to Marie.
Hi, so so the scoring, we tried to reflect the scores that we had to hand. We looked at the proportion of patients that were scoring above, say, 80%, above, say, 50%. And we talked clinically and said, roughly what would be your expectations in terms of how soon a patient might be seen. So the current scoring is based on each item being weighted 1, so they're all equally weighted. If a patient scores over 80% in their entire completed form, we would be suggesting that patients are seen within 2 weeks. If they're scoring between, say, 50 and 70, they're seen within 4 weeks. Less than that, 12 weeks. And then if they're scoring less than 10%, that a contact is definitely made to explore whether or not they need to be seen. It is being used to inform patient care. So it would be used to prioritise referrals to other services, thinking about what they can do with their patient in that appointment. But it would also be used to prioritise referrals as well and contacts, if that answers your question, I hope. And I think that...
And I think that's us, is it? So they pass to me then, and I'll say thank you very much. Okay, so thank you very much for listening to us. I hope what you found is quite useful. As I said, our emails are up there. We're on Wales at Wales. So please email us if you want any further information. There is still plenty of opportunity for you to join Value in Health Week. There's lots of sessions that I'm sure will be valuable to you all, but that's us for now. So thank you very much. Take care.